Well, hello everyone. Welcome to session 2 on real world data. This is a concurrent session and I'm Alan Katz. I am talking to you from Manitoba in Canada, namely Winnipeg specifically, which is the Treaty 1 land, the home of the Anishinaabe, Cree, Oji Cree, Dakota and Dene peoples, and the homeland of the Métis Nation. I respect the treaties that were made on these territories, and I acknowledge the harms and mistakes of the past. I recognize the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare, education, justice, child welfare, and government systems. And I dedicate myself to moving forward in partnership towards decolonization in the spirit of reconciliation and collaboration. It's Wednesday evening here in Manitoba. It is Thursday morning in Australia, in Melbourne, and it's Thursday afternoon in Auckland. You may note that I've left out Wales. We did anticipate a third speaker in this session. However, there was some misunderstanding. So Ian is not going to be with us, which is not a bad thing, but it's about 3 o'clock in the morning for him right now anyway. The focus in this presentation is on poverty and housing. So we will have two speakers who will speak for approximately 10 minutes. We're going to be a little flexible with that, considering that we've got the extra time. And that'll be followed by a 25-minute discussion period. I encourage you to enter questions into the Q&A that's available to you on the right-hand side of your screen. Start entering those questions as soon as they arise, as soon as you think of them. Don't be shy. And if you see a question that somebody else has entered, then please feel free to like that question, and that moves it up in the order of questions. So without further ado, I'm going to introduce our first speaker, who is Sharon Williams. She's speaking to us from Victoria, state of Victoria in Australia, where she is the manager of the Centre for Data Linkage in the Victoria government. However, she is speaking about a collaboration that I think stretches pretty widely in Australia. So without further ado, over to you, Sharon.
Okay, I'll just share my screen. How's that? Is that
That's perfect.
That's perfect. That's good. Well, thanks for that introduction, Alan. And I'll begin by acknowledging the traditional custodians of the various lands on which we're meeting and pay my respects to elders past, present, and emerging. And as Alan said, this is a collaborative project, and while I'm presenting, the presentation was developed jointly with Sacred Heart Mission and University of Western Australia. Oh, just having trouble moving on the slide there. Oh, there. So I'll start by talking a bit about Journey to Social Inclusion, or J2SI as it's known. So Sacred Heart Mission here in Melbourne runs the J2SI program, and it provides 3 years of intensive case management for people experiencing chronic homelessness. The focus is on rapid housing, so that's social housing, and also a form of private rental called head leasing, which involves a community housing provider holding the main lease, but then on letting the property to the tenant. There's 5 main outcome areas that include stable housing, health and wellbeing, independence, social inclusion, and economic participation. The initial J2SI program was in 2009 to 12 for 40 people. And then J2SI phase 2 was from 2016 to 19 with 60 participants. And phase 2 also included a randomised control trial, which was run by University of Western Australia with 90 in the control group. And that's of particular relevance as that same control group has formed the control group for the J2SI social impact investment. So the social impact investment commenced in 2018 and will have 3 cohorts of 60 each. So J2SI, it's a social impact investment approach. And by that, I mean that, that rather than payment by throughput, payment is by results. And there's a contract between government and the service provider about those expected results. So in this instance, 50% of the program costs are at risk based on the level of performance, and the financing structure is a variant of social impact bonds with low cost debt and contingent grants that are then paid back, assuming that the payable outcomes are met. So there's 2 measures, payable outcome measures for J2SI. The first one is stable housing, and that involves a comparison of the percentage in the implementation group in stable housing, less the control group in stable housing. Measure 2 relates to hospital bed days. So obviously seeking to reduce the number of hospital of days of inpatient admissions experienced by the implementation group. That's compared with the reduction in hospital bed days. And because it's a reduction, it obviously has to be compared to a baseline figure, and that's the hospital bed days for the cohorts in the year before J2SI started. So there's a diagram there which shows the sequencing of the cohorts 1, 2, and 3, and with the red dots being the measurement points. So the measurement will take place at years 2, 3, and 4 for each of the cohorts, and target or above performance is required to cover program and debt costs. So there's a diagram of the J2SI financing structure. So I won't sort of go into that in any detail because of the sort of time constraints. But I guess if we have additional time at the end, we can always go back and have a look at that if people want more information. So University of Western Australia is responsible for doing the analysis relating to the J2SI control group. And as I mentioned before, it's the same control group that was used for the phase 2 randomised control trial, and the same control group is used for all 3 cohorts of the social impact investment. It involves a combination of linked data and data from the surveys that were undertaken for the randomised control trial. So Centre for Victorian Data Linkage links the control group participants with the public housing and hospital bed days linked administrative data, and provides de-identified data to University of Western Australia. UWA supplements that with data on non-public housing forms of stable housing, which obviously isn't in the administrative data. And you can see there from the diagram the 8 waves of surveys at 6 monthly intervals. The intervention group, Centre for Victorian Data Linkage, is responsible for the linkage, and ourselves and our analytic colleagues are responsible for the analysis. So both the stable housing and hospital bed days measures, we use linked data. We receive the identifiers from Sacred Heart Mission and link those to the relevant administrative data. For stable housing, that's public housing tenancies and homelessness data. But that is also supplemented by some data from Sacred Heart Mission. So in terms of stable housing, in general, crisis accommodation is not considered stable housing, but it is if it's for a family reason related to family violence. So Sacred Heart Mission is aware of any situations of family violence through their interaction with the participants. So they actually enter that data into the homelessness data set. So it's considered in the calculation. For hospital bed days, we link the participants to the admitted episode data to calculate the hospital bed days and the baseline, and we compare that with the baseline developed by UWA with the control group. We need to recalculate each baselines for each cohort at each measurement date, so only active participants are compared, so any who've dropped out of the program are excluded. There was in terms of, there was concern that there might be outliers which distort the measures. So, you know, an individual might have very, very long hospital admission, and we looked at a few statistical approaches to dealing with that, but we agreed in the end that if that happens, they can be that data can be removed by agreement between the parties. So in terms of benefits of the J2SI measurement approach, I think both CBDL and University of Western Australia agree that it demonstrates the application of linked data in a real world situation for program implementation and outcome measurement, and that the linked administrative data provides additional evidence on program impact beyond self-report, as you might get in a survey, and it provides longitudinal information without sample attrition. It's also proved to be a successful collaboration between the service provider, Sacred Heart Mission, the researcher and ourselves on this common aim. But it's also presented quite a few challenges as well, and you might sort of gather from my overview of the measures that they're actually really quite complex measures, and they required a detailed level of documentation and planning. We've also found from CBDL perspective, they're quite resource intensive in terms of data acquisition and linkage work, and then there's the analytical work component as well. And because all the timelines, etc., are set out in a legal contract, there's sort of not flexibility in terms of meeting those timelines. So it's really critical to ensure the availability and timeliness of data. I mean, UWA similarly found the resources that's quite resource intensive, and they've had those they add a dimension of ethics applications. In some of the data, there's been sort of data quality issues, lack of standardization, incomplete data dictionaries, and lags in availability. We're only currently using Victorian data, so if the participants move to other jurisdictions, that won't necessarily, beyond the program, that won't necessarily be visible to us. And the size of the control group, there's potential issues with that, with a decreasing size of the control group in terms of people experiencing homelessness, the extent to which they keep on responding to the surveys. So we've learned quite a few lessons from the J2SI measurement approach as far as we've got so far. Firstly, that both of us at CBDL and University of Western Australia have learned that the documentation on the measures needs to be very specific and detailed about who, when, what and how, and the documentation that we had before we sort of did a practice run of the measures, we found that is just not sufficient in detail, and it really does need to be a step-by-step documentation listing all the processes in a lot of details. And as I said before, with contractual timelines, we really have to anticipate potential delays, whether they're due to staffing, data unavailability, or a lot of the linkage requirements for these measures are bespoke. They're outside our normal processes. And we've done practice run of the measures, and we found that absolutely essential. UWA, again, the ethics processes and consents acceptable to data linkage units need to be made clear at the beginning of projects and consistently maintained over time. So the impacts in terms of the service implementation and research side, well, certainly from a Sacred Heart Mission perspective, timely outcome payments are really essential to minimise the social impact investment borrowings and interest costs. Head leasing, which I mentioned before as being one of the main housing types. Generally, that's not considered to be stable housing. It's considered to be transitional housing, but it was agreed between the parties for the purpose of this activity, because we wanted to achieve rapid housing, that it would be considered stable housing. And the hospital bed days outliers, as I said before, we decided on a policy approach rather than a statistical approach, given the size of the cohort. From UWA, yes, so there's obviously significant research benefits from administrative data linkage, but there's still a way to go. I mean, we'd agree with this in terms of better linkage across jurisdictions and levels of government. In Australia, states hold some data sets and Commonwealth holds some data sets, and it's difficult to get all those data sets together. And across some areas, also health. Some data sets are more easy to attain, such as health and housing, compared to justice. So yes, I mean, there's a range of other areas that linked data could be used for research purposes. Related to sort of coming out of this work. I mean, certainly it could be used to understand the impact of J2SI across a broader range of dimensions. And there's in terms of payable outcome measures, there's obviously only two, but there's a lot of in terms of achievement of outcomes, there's a lot of other areas that could be looked at. Could be used to understand issues relevant to the particular cohort, so service journeys, mortality, and various sort of other issues, and also from I guess more a methodology type of perspective, comparing linked data outcomes and survey data for the same outcome, and looking at consent processes, and looking at use of and more broadly the use of linked administrative data for outcome measures. So that's basically it from me. So I'll stop sharing my screen, I assume now, Alan.
Yeah, thanks, Sharon. That's wonderful. Great. So that really was a very interesting presentation from my perspective, because in our environment we are also experimenting with social impact bonds. So just learning a little bit about them, and the data center that I direct is providing support to two of the social impact bonds in terms of data for analysis. So I'm sure we can have an interesting conversation during the discussion period about Q&A period about that. So without further ado, though, I'm going to call upon Daniel. Daniel Exeter is going to talk to us from Auckland about the work that he's presenting. He's going to take himself off mute and share his screen. And looking forward to hearing you, Daniel.
Great. Ingna mana, ingna reo, ingna manahiri tuarangi tēnā koutou. Ko Owairaka te maunga, ko te waio pareira te wai, no Portugal me te United Kingdom oku matua tūpuna, he puako aho, ki te kura haura tangata o te whare-wānanga o Tamaki Makaurau, ko Daniel Exeter aho. Kia ora, everybody, and welcome. I'm just acknowledging that from New Zealand, I'm saying welcome. My name's Daniel, and my mountain that I'm familiar with is in Mount Albert here in Auckland, and my water that my ancestral links relate to Henderson out West Auckland. I'm a proud Westie, but I also have links to Portugal and the United Kingdom through my parents' sides. Today, I'm delighted to be presenting some work that I was funded through the Marsden Fund by the Royal Society here in New Zealand, looking at using an integrated approach to measure socioeconomic position among the over 65s. And this is a great team that I've got here. Tommy is worth a mention. She's one of my master's students who's been doing some of the work in the background. So if this is all going to work for me. Just a little bit of background. Why am I interested in doing what we're doing? Socioeconomic position, typically measures of income or occupation or education are really focused on the working age population. For the over 65s, specifically in New Zealand, we are an aging population. It accounted for 15% of the population were aged over 65 in 2018 in the latest census. This is going to increase further to 22% in the next 10 years. And really importantly, we're going to see a change in our dependency ratios where for the first time the elderly dependency ratio is going to increase and go above the youth dependency ratio sometime in the next 5 years. When we think about areas of the measuring socioeconomic position, for the over 65 population, for our older people, many elderly may not be in paid work. If we're thinking about their occupational standing, the classification of females is quite difficult, particularly where they had less attachment historically to the labour market. When we're thinking about income, we've got a reduction in income for those in retirement. There's that transition towards being an income poor, asset rich portion of the population. And just as in older age, as in working age, the income can be susceptible to change over the life course. When we're thinking about the tertiary education, very few people will have that in our population. So this was a challenge that I set to put forward, and now I know why people don't do this kind of research. It is quite a challenge. Nevertheless, even when we're using working age measures of socioeconomic position or area deprivation, we still see really consistent social gradients in health and well-being. So for my research, our team used the integrated data infrastructure, which is maintained by Statistics New Zealand here in New Zealand. And specifically for the study, we used the 2013 census population as our denominator, and we linked to different data sets managing tax data, Ministry of Health data, and beneficiary data in particular from the IDI to create a cohort. We started our population with nearly 598,000 people aged over 65 living in New Zealand on census night in March 2013. We excluded those aged over 65 who were not living in, or who were living in non-private dwellings. These are institutions or perhaps rest homes. That left us with 552,000 adults aged over 65 living in private dwellings and were present here on census night. And about 47% were male and 52% were female. The little bit of text at the bottom is just a disclaimer statement from Statistics New Zealand, just outlining that the research that I'm presenting today are not official statistics, and these are my opinions, not those of the University of Auckland, where I'm based, or Statistics New Zealand. One of the challenges that we had was measuring different components of socioeconomic status for the over 65s, and this largely focused on things like health and wealth, the assets people have, and social connectedness. I say here that we have 15 variables, and we have a complete data set for 432,135 people. These are the analytic results section that I'll be talking about today. So this is a bit of a handful of a figure, I'm sorry, but essentially what we did was based on the notion of an index of multiple deprivation, which is based on domains of different types of deprivation and indicators within each domain. We devised 5 different domains in this context. We have income, which was resulting around supplementary benefits, people on low income households or receiving a main benefit from the government. And I won't read all of the 15 measures, but the key thing here was because of the different circumstances in which people live, whether it's in a couple, whether they're living mortgage-free or not, for example, the amount of money that's coming in can vary from individual to individual. So for consistency across the board, we dichotomized all 15 of these measures except for the access domain. So altogether, we have measures representing income, housing, health, assets, social connectedness, and also access to things like supermarkets, hospital services, libraries, communities, and social spaces, and so forth. All the data would combine together to create an overall index with equal weighting, and we ranked those 432,000 people from least deprived to most deprived using these individual measures. This is just an indication of the 15 indicators that we used and the proportion of the population who were deprived, if you like, those that answered yes into the census questions or in the health situations, no representing the orange. And you'll see that there are a few indicators here where between 5 and 15% of the population were missing data for some of our variables, and that's why we've reduced our overall cohort. Access to services, everybody has access to, because everybody in our cohort had a residential address for which we, or a mesh block of residents that we could link the area access measure to. This is a very busy graph, I'm sorry, but on the left-hand side, we've got the population aged over 65, those 432,000 adults in the 2013 census, grouped by district health board and the area in which they live, and the proportion of the population in each DHB by quintile of OPIMD. The dark blue here represents the most deprived proportion of the population, and the lighter blue represents the least deprived 20% of the population overall. And you can see that variably there's some variation across all of the DHBs, but there's relative consistency with roughly 20% in each one of those quintiles. If we look on the right-hand side, this is the proportion of the population aged over 65, that same cohort. If we look at the proportion of the deprivation according to the index of multiple deprivation, the IMD for New Zealand represented in 2013 combined 28 variables grouped into 7 different domains and an overall index. So the interesting thing to note here is if we look at the middle of the chart, when we look at Northland in the top of the selection set, we can see that there's about maybe 15% or 18% of people aged over 65 according to the OPIMD, whereas there's only probably 2% according to the IMD, and the proportions for the most deprived are equally quite different. For the Nelson Marlborough, which is based in the top of the South Island, they are a typically least deprived community across the board when we look at national statistics. But we can see here that the proportion of those living in each one of the quintiles is almost equal for the OPIMD, but it does vary quite considerably again, with probably only about 5% of those aged over 65 living in the most extreme levels of overall deprivation according to the conventional IMD measure. In the interest of time, I'm not going to go through a whole lot of measures, but this is the bottom graph. The bar graph at the bottom shows the quintiles of the OPIMD and the IMD according to the population aged over 65 with no vehicle access, which was one of the questions in the 2013 census. So as we would expect, there is a social gradient. The red bars here representing the IMD, the overall population working age statistics largely, but the OPIMD here shown in blue shows that about 25% of those people living in quintile 5 have no access to a motor car, much higher than those classified quintile 5 according to the IMD, but also you can see that almost exponential growth from quintile 1 through to quintile 5 according to the OPIMD. We chose 15 indicators, or we selected 15 indicators based on a set of criteria about data coverage and completeness. We did go through many indicators, probably close to maybe 100 indicators were considered, measuring things like whether people were only receiving the New Zealand super or our pension payment, whether they were receiving family tax credit, levels of education or the age at the end of education are commonly used in qualitative surveys or smaller cohort studies. When we were thinking about connectedness, we were wondering about years living in New Zealand or religious affiliation, maybe whether they spoke English is clearly a hindrance or perhaps a barrier to some access to services. There are many health and mobility things that we were also really keen to try and measure that were specific to the over 65s. Use of a gold card, which is the over 65 senior service card. They have free public transport after 9:30 on our public transport route. This would have been a really, really useful measure, but unfortunately it wasn't widely available. Those data from the different organizations weren't in the IDI, and they certainly weren't available consistently across the whole country. So just to discuss a very quick presentation, to our knowledge, this is the first whole of population measure of older persons multiple deprivation. It's a measure that's specifically for individuals. There are some studies that we are aware of that are similar to the IMD, where they just use one domain of income, for example, in the UK. And there is a global measure which is available, which uses ecological data for each country for about 200 countries around the world, or nation states. They give us an indication of sampled ecological data. This is the first whole of population indicator that we've done for the 432,000 people that we could get complete data for. The OPIMD does act as we would expect, with showing social gradients as we would expect based on what we already knew with existing measures of deprivation, although there are some quite subtle differences. The motor vehicle access, even though it was a quick prevalence study that we showed you today, we can still see that there is something. Being more deprived and being aged over 65 is a further heightening risk there in terms of access to services if you don't have access to a motor vehicle, for example. Data integration is both a strength and a weakness. Having the IDI has been a fantastic resource. We can get a one-stop shop where we can do our data linkage across many different routinely collected databases. And it allows us to capture all different kinds of deprivation and or well-being. The lack of data coverage and or completeness is problematic, and this is most relevant to those people aged over 65 living in residential care for older people or perhaps rest homes. This comprised about 5% of our population, and most of the indicators that we were interested in, their household income, whether they were paying rent or had a mortgage, are perhaps not relevant to the population living in a rest home, but many of their other census data is relatively poor as well. There is an internationally recognized standard called the INTERI, which is an instrument that assesses the type of support that older people need to have to live at home independently, or whether they need to move to an aged residential care facility. That is now available online in the IDI if we're wanting to grab hold of it. It wasn't available at the time of the extract, so that would have been a really, really useful measure in terms of not only connectedness, but certainly a health measure as well. Going forward, we'll probably use the INTERI as an example for us to test those social gradients in a little bit more detail. one of the real strengths of the IDI, of course, is that as data improves, as we use it and publish it more widely, there's a little bit of an impetus for different routine collectors of these data to improve the data collection or to improve data dictionaries and so forth. So a massive thank you to the Statistics New Zealand IDI team for all of their ongoing support. One of the limitations for doing the research in the IDI for all of the linked cohort is that the information is not available to the general population as a standard survey. However, we have been working at the back end to create an OPIMD calculator, which essentially uses the 15 questions based on where you live and the 15 questions in the IDI, which are dichotomized questions, a simple survey that gives you a calculator that then you can enter in the details, and you'll get essentially the decile of the OPIMD ranking that you would be typically subscribed. So hopefully that gives you a rough indication of the work that we've been going through, and I'll hand it back to the chair. Thank you very much.
Thanks, Daniel. That was great. So we took advantage of the fact that we had one less speaker, and we're given the two of you who arrived a little bit more time to share your information clearly, and you've both done a great job in doing that. So thank you to both of you. There are a number of questions in the chat. Not surprisingly, the questions start off with questions for Sharon. So let's start off with one of those. And I see that there's been some conversation in the chat with Suzanne Finley answering some of those questions already for you, Sharon. Nevertheless, let's just have a look at that. The whole idea of the payment by results contract was questioned by Paula Brown. And this is the whole idea of a social impact bond. I think it's a novel concept. I don't know how many other countries it's being used in right now. I know it's controversial in some respects in terms of some of the social impacts of it. So I'd be interested to hear you describe that a little further, Sharon, as has been requested. Just take yourself off mute, please.
Yeah, sure. And thanks to Suzanne, who's from Sacred Heart Mission. So was one of the other contributors to the development of the presentation. Yes, so there's a contract between Victorian government and Sacred Heart Mission. It's actually it's signed by the relevant Victorian government minister and by the CEO of Sacred Heart Mission, and it's about 80 pages long. It's called an implementation agreement actually, but it's effectively a binding contract, and it really sets out in a lot of detail all the requirements of the program, including those measures, and it sets the measurement points and exactly how they should be calculated, etc. So yes, when I was sort of saying, you know, that in terms of challenges, that it is they're complex measures, even though there's only two of them. They're complex to calculate, requiring data from different sources and a particular sequencing. And there's not sort of leeway because everything's set out in that legal contract. There's not flex, you know, you can't say, oh, well, bad luck, we're not going to be able to meet that that date. We need a bit more time. So yeah, I mean, that is that's you know, quite a challenging aspect of it.
Yeah, so one of the questions also asked about the availability of measures, or including measures of comorbid disease, for instance, mental disorders or substance use, which clearly would be expected to impact upon housing.
Yes, so with the social impact bonds, I mean, the Victorian, this is J2SI is one of the first two. There's another one called Compass, which I'm presenting on at a session tonight. With it's a young people leaving out of home care bond, and that's so J2SI's got 2 payable outcome measures, and Compass has got 3. So I suppose the but I mean, everyone would acknowledge that they're not the only outcomes that we're interested in terms of the effectiveness of the service. But I think in terms of developing something that's sort of manageable and achievable, the payable outcome measures have been kept to a relatively small number, and sort of other aspects of outcomes might be considered through broader evaluation, but not actually and not actually payable. So in terms of yeah, I mean, I think there's obviously a range of other sort of factors that are of interest, but they're not sort of currently being considered. They're not being measured in J2 in the social, as part of the social impact investment. But I think Suzanne did post the link to the randomised control trial report, which had a broader range of measures. I don't think those particular ones that were raised, but certainly sort of broader than those 2 that are being measured as part of the social impact investment sort of payment side of things.
So we all who use real world data are aware that real world data has both significant advantages in that we don't have to collect data specifically and it's there to be used, but the disadvantages are there too, in terms of they can be messy. And I think that you did allude to that in one of your slides, but I wonder if one of the challenges, one of the questions I had when you presented, when you alluded to this to some extent, was the issue of measuring hospital days as as the outcome, and how that was decided as the outcome rather than, for instance, discrete hospital admissions.
Yes, an interesting question. So with the social impact bonds, there's a very long lead time, which is called the joint development phase, which is really a sort of collaborative design or development of the social impact bond response of jointly with between representatives of government and the service providers and sort of other sort of relevant stakeholders, and the actual measures were decided as part of that process. So I wasn't specifically involved in that joint development phase, so I actually don't really know exactly what the thinking was around making that specific decision about why that particular measure. I mean, I think Suzanne might have just sent me about it, because I think she because there was sort of 3 of us yeah, because there were 3 of us sort of developed the presentation. Some have more knowledge on one aspect than the other, but I think it's a challenge to decide what is the sort of best measure for the payable outcome measure, and it's got to be something that is obviously relevant to the program and can be measured, but also that it sort of doesn't have sort of that it's sort of fair towards both government and the service provider, and being able to sort of deliver on that. So while I can't comment specifically on that, I can say there was quite a long involved collaborative process of working out and looking at the data also. I mean, it was very both those first both the social impact bonds are very much data driven, so there was a lot of considering the data and what that told us. And with J2SI, because there'd obviously been those previous 2 iterations, so that it was possible to sort of learn from also what the outcomes of those have been. So
Thanks, Sharon. So, Daniel, I'm going to ask you a question that doesn't appear in the chat, but just following on the concept of the challenges of using real-world data and it not necessarily giving you everything that you particularly want. You chose to exclude indicators where you didn't have a 100% response rate for those, rather than using statistical methods to adjust for missing data. You want to expand a little bit on that? Just take yourself off mute, please. You're on mute.
Yep, absolutely. That's a really, really good question, and one which was largely driven by pragmatism, I think. It was a funded project that had a limited shelf life in terms of being able to pay our team members. And one of the great things about having access to the data is the ongoing availability, but one of the challenges is the time it takes to get your teeth into the data and understand how the data operate for you. So we probably focused a lot on getting the product out rather than how best to statistically control for missingness in this instance. But that's always room for improvement and part of a subsequent piece of research I think we'll definitely be doing in order to be able to present a product that we were confident in. I think it was, I've got a biostatistician on team, and she was more for the case of omitting 5% of the population or so than doing some statistical inference on them.
Yeah, so that's the challenge of, you've got to latch, not 95% of your sample is included, so that's well, pretty good.
It's about 78, all up, we've got 78% of the over 65s included in the cohort. So that's still a reasonably good cohort in terms of response rates of a survey, if this was a smaller survey. And it also gives us that opportunity with using the real world data. One of the other challenges we had was if we were, one of the variables we had was whether there was a cancer registration. And you know, there's many ways we could measure survival or the likelihood of outcome in terms of having been a cancer having cancer registered, but we didn't really have a lot of detail around your well-being on a full recovery or a complicated recovery. Are you still in remission 5 or 6 years after, for example? So that was also one of the drivers as to why we dichotomized our variables rather than being able to use a severity score for some of the cancers based on stage and site, perhaps at the time of diagnosis. We kind of made a more broad approach than what you might ideally have done if we were just doing an analysis of cancers themselves, for example.
So Daniel, there's a question around from Lisa Sherwood about the OPIMD metric and how it was developed, where it came from. I would add to her question as to the decision not to provide any weighting, for example.
So again, I think the ideas that the components of the indicators and the domains themselves were largely driven by the headline acts, I guess, of the literature around what's important to the over 65s. There's a lot of information around assets and wealth and connection and loneliness, and there's some questions that we would have loved to have included around you know, a loneliness measure, for example, but we couldn't really get that captured for a whole population. In terms of the metrics, again, in this case we opted for the equal weighting in this instance, but again, that's a little bit more research that we could develop further. we've seen in the work that we did developing the IMD, and there's other research that's been done for the international indices of multiple deprivation for the whole populations, such as those in Scotland or in Wales, where if we altered the way, if we changed the formula, we don't necessarily change the weightings of the overall picture of deprivation. And so at the moment, while they're equal weighting, with the exception of the access domain, the access domain only holds a 2% weighting from memory. That is largely because access is an urban-rural indicator, and if you live in the central Auckland area or a CBD, you're going to have amazing access. If you live 20 kilometres out, you're going to have somewhat good, and if you're 40 kilometres out, then you're going to have, you know, substantially worse access. So that was the one that we made the decision that it didn't really reflect a deprivation circumstance as well as we might have liked. Nevertheless, we felt that having access to those resources was still important, and to capture that. Again, that was largely driven by our team, and there's many ways we could have combined it, and open to suggestions on how we could do that further. Yeah, happy to have a discussion.
I think it's a fascinating approach you've taken with lots of potential for exploring different options. I want to just, we've got about 90 seconds left. I want to ask, you each have alluded to the fact that this kind of work is messy in terms of getting permissions. It always takes longer than expected. You were constrained to some extent in what you did by the length of funding and things like that. So any wisdom that anything you would do differently in that regard, or wisdom for others wanting to work with real world data from either of you?
If I go first, I think with all research projects, we always are extremely optimistic in what we can achieve in the 3-year window. With the big data and using the data sets we use, I think we need to peel back and be realistic. I wouldn't say conservative, but be a bit more realistic in some of those outcomes. I'd also point out that in the middle of our research phase, there were the Kia Ora earthquakes here in New Zealand, in which the Statistics New Zealand office that we were sourcing our access to these data from was closed for about 6 or 8 weeks while we set things up. So yeah, working with government agencies and seeking their support throughout is that open door policy is definitely worthwhile.
So we do only have about 20 seconds left, so I'm going to, Sharon, unfortunately not give you a chance to answer that.
Sorry.
I want to thank you both. Very interesting work. Congratulations on your work. And I want to thank all of our participants and for their questions, and the organizers for a wonderful conference so far.